Okay, everybody there. Good afternoon, everybody. I'm very happy to be here virtually with most of you. I'm Lieve Fransen. I'm a medical doctor. I worked for a long time in the European Commission, and I worked also a lot with the EPC. And I'm a social an advisor, senior advisor with the EPC and with the King Boudewijn Foundation. And so I'm very happy here to moderate a very important discussion on dementia specifically around populations with a migrant background. We will first start with an overview presented by the Bosch Foundation and the KBF. But I would like to introduce with a few points, and then afterwards we will have a panel debate with very important people. I'm really impressed by the group of people connected here and presenting slides and findings. And then I hope we will have time enough to have discussions and questions from you. First, a practical thing. Simona, she is online and she will collect the questions. So while people are speaking, you can already make your questions, but preferably in the chat box. So we don't take questions in speaking questions, because I think that's going to complicate things. So Simona is going to collect the questions and make sure that I have the questions, and that she will also put them forward to the audience and to the speakers when it's time for question time. But you can already, during the time of the presentations, do so. So don't wait until the last minute. First of all, dementia itself is really a leading cause of disability and dependency among older people worldwide. And I'm quite impressed by the figures that I read from many of you, in a way, is that 10 million people in the European region have dementia or living with dementia. And that incidence is set to increase and double by 2030. That is quite a scary proportion of our population. As our population is aging, of course, this is understandable, but still, it is something that needs urgent attention, clearly, and maybe more than has been given up till now. It gives, of course, people living with dementia have an individual problem, of course. They're also a burden, very often, or seen as a burden or difficult to manage by their families, the carers, the family, and so on. They also have a social impact, a social and economic impact that is important. The healthcare systems very often and the social care systems very often are not sufficiently prepared. And all of this is aggravated, of course, in the situation of migrant backgrounds. And I think that's really what we want to focus on today. And I just want to mention also that in COVID times, we are also working virtually, but it also has really an impact seriously on loneliness, anxiety, and people with dementia very often suffer even more from that kind of situation in COVID times. So let's give some attention to all of that in our webinar. I would like to congratulate really the KBF, EFID, and NEF, and the EPC for working on this topic since many years, and to bring up now for the first time really the issue of people living with dementia among migrant populations. The objective of our event is to raise awareness about the situation of people with migrant backgrounds, to fill the knowledge gaps, and some of you have really fascinating data already, to help and to catalyze the EU-level research on these topics, and to showcase best practices, and hopefully to put dementia and mental health, including among migrant populations, on the EU agenda. So that's our challenge for this webinar. I excuse myself for many of you. You have beautiful CVs. I read them with a lot of interest. I also read most of your slides with very interest that I received and presentations. But I will not go to extensive presentations of each of you because that would take a lot of time away from the real key discussions that we should have. First of all, Gerrit Roos and Bernadette Klapper will give an introduction about the 10 years of work on dementia, people living with dementia. And I think you have slides and a video, Gerrit and Bernadette, so I leave it to you. You are invited to speak. Gerrit is a director of the health program at the King Baudouin Foundation. He also has, I know Gerrit quite well, he has a long experience in the Foundation, but with very critical work. Bernadette is a trained nurse. She is a PhD and she has French and German diplomas, and she is the senior vice president of the Robert Bosch Stichting for the moment. The floor is yours, both of you. Okay.
Thank you so much. My name is Bernadette Klapper, as I was introduced. I'm happy to open the initial greetings of the foundations, form a partnership within EFID, which stands for the European Foundations Initiative on Dementia. EFID is a program led by 5 foundations across Europe. It's the Robert Bosch Stiftung in Stuttgart, the King Baudouin Foundation in Brussels, Fondation Médéric Alzheimer in Paris, Fondazione Compagnia di San Paolo, and its Porticus, and we are all hosted by the network of European foundations, which is also located in Brussels right away. EFID has been created in 2010, so 10 years ago, with the aim of improving the lives of people with dementia and promote dementia-friendly and inclusive communities in Europe. In the past 10 years, we have been working on our partnership with foundations and different organizations to really change the perception of dementia, proposing new framing of the condition that fights the stigma. Furthermore, we worked on the empowerment of people with dementia, promoting their involvement and meaningful participation in the local community. We have done this through 3 working streams. The first one was the award scheme. The award scheme, Living Well with Dementia in the Community, in 2012 and 2014, and the award scheme Valuing the Expertise of People Living with Dementia in 2017, supported 32 organizations and 15 countries across Europe. In 2020, one more round of awards is currently open to reward the organizations that played an active role in supporting people with dementia during the COVID-19 pandemic. The second stream is that EFID generates knowledge and enables the exchange of best practices among the awardees. In 2012, EFID published the leaflet I'm Still the Same Person to provide recommendations on how to communicate on dementia. In 2015, we published a mapping of dementia-friendly communities across Europe to demonstrate the diversity of practices that exist and that could be scaled up and replicated in other contexts. In 2020, EFID published a toolkit for planning, reflection, and learning to help professionals and practitioners monitoring, evaluating the initiative. The third stream is the capacity development. Every year, EFID offers the opportunity to meet and exchange among awardees on different topics. During the COVID-19 crisis, we organized webinars to exchange and reflect on dementia-related matters. I'm very happy to be with you today, and now I will hand over to Gerrit from the King Baudouin Foundation, just couple of words from the Robert Bosch Stiftung. We have been working in the dementia field since 2003, and we are really very happy to see the partnership growing and how far it has brought us. And personally, I am very happy that we really can raise awareness now for the very important topic which we all share. It's the topic of dementia and migration across Europe. I think we can help each other tremendously in going this road. So this is from my side. Very warm welcome, and now over to Garrett.
Good afternoon, everybody. So thank you a lot, Bernadette, for this kind introduction and the overview of our 10 years of work. So I will have a very short introduction. What did we learn? What did we learn over those 10 years? And we did this by drawing some guiding principles of what integrated community care means for people living with dementia. How can we guarantee that we build inclusive communities for all, with a special focus for people living with dementia? Guiding principles are not rules. They guide your work. You never fully achieve it. But if you take them all into account, you have a sort of a framework to monitor the work you're doing and to evaluate the work you're doing. The first principle is, and the first two are, well, they're all important. The first one is the one which is at the origin of EFID. It's to enable the highest quality of life to be made possible for people with dementia, with the fewest restrictions as possible on their personal liberties. And every effort should be made to preserve their dignity and independence throughout all the stations of the condition. That's really what was one of the driving forces of EFID. The second one is to foster the active inclusion and involvement of people with dementia in all aspects of life, including life in the community, in cooperation with the communities in which they live in, while ensuring their health and well-being. There's no one-size-fits-all approach, and therefore we really need to involve all community members, and the diversity and the inclusion of the groups that may be marginalized, for ethnic or other reasons, need to be ensured. The life goals of people with dementia should be the starting point for the design of all health and social care interventions that relate to the specific care needs of them. The third guiding principle is to raise awareness about what is needed to increase the well-being, resources, and potential of people with any cognitive impairment and of their family carers. We really have to contribute to changing perceptions of such people with dementia, and that needs a society-wide change in the mindset. We have to frame dementia actively and nuanced, especially in the media, to change the negative image of dementia among the public. The fourth principle, which was also very building in our activities, is to build partnerships, networks, and collaborations among various stakeholders and organizations to produce well-being. We have to integrate a crucial role played by health and social care organizations and dementia specialist organizations in the development of inclusive communities. We have to create synergies between civil society organizations, formal and informal health and social care services, and family carers and professionals. The fifth guiding principle is on prevention and diagnosis. We really have to invest in prevention and health promotion while reducing health inequalities. We have to ensure the early screening for dementia for everyone, including people in remote areas, followed by timely diagnosis and prompt referral for services. All this requires the sixth principle: coordinated strategies. We have to promote the adoption of dementia strategies in every country in the EU, in collaboration with community and all stakeholders at local, regional, and national levels. And that requires adequate resources and strategies, where national, regional, and local governments can all play a role. And the seventh and last guiding principle is to evaluate and adapt permanently. I said these are guiding principles. These are not rules, so we need to adapt our initiatives by taking into account our lessons learned. We have to collaborate to evaluate the impact and outcomes of our projects, enable joint learning, and ultimately adapt policies, services, and activities. The current COVID-19 crisis has amplified the need for a more holistic approach to health and well-being. And that requires focus on the individual life goals of everybody, including people with dementia, but also a focus on health and well-being as a collective public good. All these lessons learned are written down in a brochure which is presented today on the website of the network of the European Foundations. And we have a glimpse now of a very short video that will give you a brief overview for its content. I wish you a very interesting session this afternoon. Thank you.
Thank you, Bernadette. Thank you, Gerrit, and thank you for all of the teams behind this, because this is 10 years work of great teamwork, I believe. So your principles are incredibly challenging and promising. And I hope really that we can help making a step forward in the next days and months, and how this can make a difference really for people in really difficult situations and families. I have one problem as moderator at a time. We are already a little bit over time, so please, the next speakers, can you try to keep time while sharing with us your interesting know-how and knowledge and information. I would like to invite David Truswell, who is the chair of the Dementia Alliance for Culture and Ethnicity. I believe you also have some slides, and you have and you're the editor of a recent book supporting people living with dementia in Black, Asian, and minority ethnic communities. And you will share with us your, all of the things that you learned, but in maximum 10 minutes, okay?
Okay, thanks very much. I should say that I don't have slides, so I'm just going to say what I've got to say. Thanks for you inviting me. I think this is an important issue to have on the radar at this time. I'm just going to highlight mainly my experience in the UK, but I know from presentations I've done at various conferences in the last few years, a lot of what I've said we're going to have implications also across Europe. So let me start firstly with the situation in the UK. One of the obstacles for effective planning for dementia is the lack of information at the kind of local council or borough level, at the actual age structure of migrant organisations, which means that often nobody knows really how old most people are in most of the communities that are migrant communities. And also they don't know much about the history of migration of those communities, which means in those local circumstances for councils, there's not any distinction really at the planning level often between settled migrant communities where a substantial number of people may be older, and also a substantial number of people, maybe people who came to the host country when they were younger or young adults and have grown old in the host country and have a totally different set of expectations about health services than people who may be either new migrants or migrants who've come into the host country as middle-aged people or elderly people themselves. I think also there's a sense in which there's an assumption that I think we need to throw away, which is that migrant communities look after their own. I think in relation to dementia, it's such a complicated issue, and particularly with older people with dementia, that means that people are living with other health issues as well as their dementia. So their care and support is quite complicated. And as people living with dementia live longer, because their general health is in many cases improved from some years ago, that often people in migrant communities don't realise that they may be supporting people with a very complicated illness for many, many years. It certainly means in many cases, people have underestimated their own health and care needs in terms of looking for after their own mental and physical well-being. And certainly at the planning level, there's not much planning done to actually focus on those issues for migrant communities. I think when we begin to look at what migrant communities think is available from services, the picture is quite complicated. I think it comes as no surprise to kind of find that there's a degree of stigma around dementia as an illness within a lot of migrant communities, and a lot of that's associated with the stigma towards mental health issues. But as well as that, I think there's a lot of straightforward lack of knowledge in communities. I mean, I certainly come across situations in community groups where particular communities think that dementia doesn't happen in their communities. And they're very sadly mistaken. It comes as a surprise to them that they're just as likely, or in some cases with some communities, more likely to be at risk of dementia. I think also that there's the problem for migrant communities, their anxiety that they might experience structured discrimination as a result of trying to approach services. So they may not be confident that even if they do try to approach services, that they'll get a fair hearing. And certainly there's plenty of evidence in the UK in relation to mental health services, and particularly for the Black minority communities, that there's a long history of institutional discrimination in treatment and response. And I think also an issue that's not much focused on, but is really significant in terms of people making those first approaches to services, is people's sense in migrant communities, particularly of their independence and self-reliance, which will be a strong part of their understanding of their identity and particularly for people who are first generation migrants, and facing up to the idea that they're going to lose that self-reliance and lose that sense of independence as a result of the development of dementia is often an issue that takes people a long time to come to terms with. And that often makes a contribution to people being very reluctant to approach diagnostic services. I think also an element for minority communities to struggle with is the economic challenges that they're faced with, just in terms of their access to care. It becomes more of an issue, particularly when people are moving into care homes, but that can include things like people's access to culturally appropriate food, which doesn't just mean the food itself often, but also how it's prepared. It can also mean people's access to personal support services, including grooming. It can also include people's access to faith opportunities to worship, access to social events that are important for them and their sense of belonging. It can also include people's access to things like entertainment resources, newspapers, TV programs, things of that nature. Often people have to pay additional costs to kind of meet those requirements on a day-to-day basis. And for migrant communities, as we all know, in a lifelong basis, they're less likely to have in later life as good pensions as people in the host community, because they have less access to reliable long-term employment. They're more likely to have been employed, when they are employed, at less remunerative roles. They're less likely to have their own homes. So generally, they're less likely to have that access to personal financial support, while at the same time more likely to need additional funds to actually supply those necessary additional elements to their care when they're living with dementia. So very quickly, in the last minute or so that I've got, I'd say that the summary issues for me are: one, having good quality information at the local level that actually differentiates between migrant communities and allows a focus on these differences between age structure that are important for understanding how you structure raising awareness and how you structure supporting minority carers. I think it's also about really throwing away this tired notion of communities looking after themselves and looking at how do we support communities to help, particularly family members where they're family carers, look after family members living with dementia. And how do we understand the complexities faced by minority communities that takes us out of the preconception of pondering about simply the cultural distinctions, which fair enough may well be leading to issues like stigma, but these structural issues like institutional racism and these structural socioeconomic issues, which suggest, certainly to me, that migrant communities are coping with far more when they're having to think about supporting family members with dementia, and far more likely to have a hard time accessing services, and generally are more likely to attempt to struggle with something that will overwhelm them more often than they are ready to realise.
Thank you very much for your very fascinating knowledge and competences in all of this. It's incredible that people with mental health and people from migrant backgrounds really have to, on top of that, live with stigma and discrimination, on top of everything else that you refer to. Thanks for keeping time also. I will now also invite René Thirian. He is the leader of research in the German Center for Neurodegenerative Diseases in Rostock, Greifswald. He's trained in psychology and medicine and has a fascinating range of research projects, and one of them is the EU Atlas for the Prevalence and Healthcare for People with Dementia and a Migrant Background. Please, René. Yes, you have slides here. We cannot hear you. Yes, okay.
Okay, can you hear me now?
Yes, yes.
Okay.
We can hear you. Welcome.
Ladies and gentlemen, thank you for giving me the opportunity to talk about the topic of dementia and migration at this meeting. Migration is a truly topic of high interest and needs for action for various reasons. Today, I'm glad to focus a little bit on dementia. My name is René Thürian, and I'm leading a group of researchers at the German Center for Neurodegenerative Diseases, DZNE, in Greifswald, Germany. The work I'm presenting here is based on precious work of Tim Schmachtenberg and Jessica Monsees. We are approaching the European topic of dementia and migration from an epidemiological research perspective and are funded to do this by the Robert Bosch Foundation since 2019. When we are talking dementia and migration, there's a need to talk about some current challenges in research. And the challenge in research should be on the next slide. Yeah. Many things are unclear from a research perspective, beginning with the heterogeneity of the topic. Who are we talking about? The so-called target group is defined or conceptualized differently in different countries. Countries with different historical backgrounds, when talking about colonies, wars, changing of borders, economically triggered migration, etc. Terms like minority, indigenous people, cultural background, etc., etc. There are lots of words how to describe. So what are we talking about? Also in dementia, dementia is a chronic disease. So what is specific to migration? Migration is sometimes associated with economic status, educational level, and others. Parameters that differ in any country, regardless of cultural background, and that have shown to impact dementia care. There is no such person as the person with migration background. So when we phrase the term people with migration background, aren't we jumping too short? Isn't that a useless generalization? And we are talking about data about this population that is scarcely available and of different quality on a European level, which diminishes comparability. There is a need for standardization if you want to achieve the European perspective. So, what we have done is to quantify, illustrate, and compare the topic of dementia and migration across the EU by analyzing first, prevalence data by country and migration background. Secondly, treatment guidelines with reference to migration background. Thirdly, analyze national dementia plans. How do they address migration? And fourthly, provision of services aiming at people with dementia in the currently running healthcare system in each country. Our overall aim with this work is to raise awareness, provide information for policymakers, stakeholders, people in the field, and nonetheless encourage more research and discussion. This is work in progress, but the Robert Bosch Foundation is aiming to publish a EU Atlas with the results in early 2021. What are some of the results? We are providing maps like these. For each country, we show how many people with dementia and with a specific migration background are assumed to be in that country, based on publicly available data. The example here is the Netherlands, and we illustrate the 5 most frequent countries for the Netherlands. You can see 153 out of 100,000 people of the general population are expected to have dementia and were born in Indonesia, 785 in Suriname. This will already illustrate that countries do have extremely different profiles, which again has implications if you look from a European level. Looking at the different countries has given us researchers already some new insights. Very often the notion of migration and its challenges are biased by our own country of origin. Coming from Germany, I expected Turkish or Polish to be more prevalent. With these maps, we already may be able to give a much more differentiated picture and also fuel the discussion what effect migration has or should have. One can argue that people with German background in the Netherlands may be culturally similar and thus do not need as much tailored services as other people with less comparable cultural backgrounds. But one can go into more detail. And as an example, we look at the regional distributions of the people in the Netherlands. Here you can see the absolute number of people with dementia born in Indonesia per region, and thus identify the magnitude of the challenge is bigger in Rotterdam, Amsterdam than in the West. More than 300 people versus less than 100. So this information is worthwhile when thinking to install migration-specific services, supports, or even just knowing who your target group might be. In some bigger countries, we can even go into more detail. And for example, in Spain, please do not try to read the small letters and numbers here. This is just for the sake of illustrating. In Spain, the largest groups differ per region as well as the distribution. Southern Spain, many British. Mallorca, many Germans. Central Spain, people from Morocco, Argentina, Romania. We think that this information on a European level alone can help to develop a more tailored strategy to tackle the challenge of providing health care for all. Across whole Europe, we will be able to estimate numbers per country of origin, so a European strategy aiming at people from a specific country is worthwhile for many countries. Furthermore, we compared national dementia strategies across Europe. This is published in BMC Public Health, and we found that basically migration plays a subordinate role here. Only 10 out of 23 countries refer to the topic, and only 3 refer to currently available services for people with migration background. This is on a national level and does not reflect the situation that there might be regional lighthouses or good models of practice in certain areas in some countries. We analyzed treatment guidelines and also found a subordinate role of migration reflected in the small number of guidelines referring to migration. 3 countries do so. In detail, Norway, Sweden, and Iceland. The main topic or open field described as the diagnosis of dementia. One key is the consideration of cultural background in diagnostic and care. Currently, we conduct expert interviews across Europe to find out more about this. It's more qualitative, about more what is happening in these countries from a more grassroots perspective, and hope to be able to summarize this pretty soon. So what is our resume? What is needed? For research, we think that research cooperation across borders, the EU, is needed. We need to develop a European thinking. We need better and more data from comparison, standardization, and knowledge transfer. For healthcare, we need enhanced diagnostics as a requirement for improved provision of healthcare. We need access to the existing system and its services, and how to solve the lower utilization rates in some people with migration background, and more cultural sensitive healthcare systems where needed. Thank you for your attention.
Thank you, René. Very fascinating how you have, despite the fact that data are not available or comparable and standardized, you came up with quite an impressive presentation already. And I hope we can go further in collecting these data at European level. I would like to now invite Diana Gove. She is a director for projects in Alzheimer's Europe. And she has a master in education and psychoanalysis, and she has a PhD, University of Bradford. And I think she's chairs for the moment the Alzheimer's European Ethics Working Group. Please, Diana, the floor is yours. We cannot hear you, Diana. I think you're on mute.
Yeah, okay, can
Yes,
you hear me now?
yes, now we can hear you.
So, whilst a lot of progress has been made with, whilst a lot of progress has been made in recognising the need for intercultural care and support, and there is an increasing awareness of barriers and challenges, there's a limit to what can be accomplished without the support of policymakers at different levels. Governments and other policymakers have a moral and legal obligation based on the principles of non-discrimination, human rights, beneficence, non-maleficence, and respect for human dignity and personhood, to ensure equity in the provision of dementia care and services. This obligation is based on governments having signed up to the provisions contained in a range of European and international documents, such as the European Convention on Human Rights, the UN Sustainable Development Goals, the European Pillar of Social Rights, the Convention on the Rights of Persons with Disabilities, to name but a few, bearing in mind that dementia is considered as a disability as well. Also, the EU is starting a new mandate, including the forthcoming EU for Health programme, which is about promoting the well-being of all people of all ages and ensuring that everyone has access to affordable, high-quality healthcare, and that all and everyone mentioned in this goal must include people from minority ethnic groups, migrant backgrounds, and their informal carers. Person-centred care, the gold standard for dementia care, and reasonable accommodation, the principle enshrined in the CRPD, cannot be provided or be said to have been achieved without cultural awareness, sensitivity, and competence. We therefore need to get policymakers on board who are committed to ensuring that real change occurs. It's not moving. Besides the problem with the slides. Can anybody help?
Okay, we have a problem with the slides.
Diane, just do it like any PowerPoint, just with the arrow, next one. Otherwise, I will share my screen.
It's not working, the arrow.
Okay, Nathalie, can you take over?
Or I can just carry on without the slides, possibly.
Okay.
Okay, so with regard to the challenges surrounding the development of appropriate intercultural care and support for people living with dementia, a major challenge is to ensure that it corresponds to the wishes, needs, values, and cultural backgrounds of people from a wide range of ethnic groups. Alzheimer Europe's expert working group looked at intercultural care and support, not just in terms of a range of services, but more globally at the big picture. So the challenge is not only to develop good services, but also to ensure that people from all ethnic groups, first of all, know about dementia, would know if they or a relative was showing signs of possible dementia, have access to timely and accurate diagnosis, and would know not only where and how to access services, but would find them appropriate and would actually want to use them. So the first global challenge is to raise awareness about dementia. People understand and try to make sense of dementia in different ways. For example, as a natural part of aging, a test or punishment from God, result of poor care or neglect, or a mental disorder. And for the first three, this can be problematic if dementia is not also recognised or accepted as a medical condition, because this could result in people not being aware of or not accessing the support, care and treatment that's available within the healthcare system. Information about dementia and services and channels of communication are often culturally biased, not suited to the language abilities, level of education, belief system, or values of many people with migration backgrounds. Many older people who migrated to Europe are not fluent in the national language, and some do not read or write in their own mother tongue. In some languages, there's no word for dementia in everyday usage, and the words used to refer to people with dementia are often derogatory or inaccurate, leading to further confusion. The next challenge is ensuring timely diagnosis and accurate diagnosis. And people with a migration background often don't receive the same standard of diagnostic evaluations for dementia and may be misdiagnosed. Although biomarkers are increasingly playing a role in the diagnostic workup of dementia, dementia is still very much a clinical diagnosis, which relies on verbal interaction, observation of behaviour and cognitive assessments, and this raises several challenges. Most assessment and diagnostic tools for dementia, which are used for people also with a migrant background, are not culturally sensitive, and have not been validated for those groups. Translation alone doesn't make them culturally appropriate, and there's a distinct lack of access to professional interpreters. Using relatives as interpreters may be practical and a readily available solution, but interpretation is a complex skill which requires specialised training. But language isn't the only factor affecting the appropriate use of assessment and diagnostic tools. Cultural and educational bias also needs to be considered. The third key challenge is to address barriers to help seeking and service uptake. And there are a number of barriers that prevent people with a migration background from seeking help, or to them only seeking help when the situation has actually become a crisis. So in some ethnic groups, the stigma is not so much the condition itself, but rather what the condition implies, namely that someone has sinned or is being tested by God. And so then seeking help would draw attention to this wrongdoing, or could be seen as rejection or failure of the test. Many people with a migration background consider it their duty to care for relatives, and using services could also be perceived as failing to fulfill those duties. And then this perhaps fuels the belief that they look after their own, as David mentioned earlier, and do not want or need support. But also it makes it difficult for the people who do want support to seek and obtain it. And then there are other barriers that also have already been mentioned, such as mistrust of healthcare professionals, low levels of literacy, and also, excuse me, not taking part in research, which influences services. Moving on now to the question of how to promote more inclusive and culturally sensitive health and social care services. Implementation and sustainability are key priorities with regard to policy at different levels, and overarching high-level policies provide the basis for what needs to happen. But locally and nationally, detailed policy and practice must be developed to make this a reality. So I've got a frog in my throat.
I can give you some water.
I've got some things. So at national level, government should work together with people with dementia and carers from minority ethnic communities to address barriers to diagnosis and the uptake of services linked to language and literacy. How? By ensuring that assessment and diagnostic tools are culturally sensitive and properly validated, that people have the right to be assessed and diagnosed in their own or their best language, and that they have a right to an interpreter if needed. Further measures include agreeing on standards for professional interpreters and intercultural mediators, establishing guidelines and even restrictions for the involvement of lay interpreters, although they're very valuable, taking measures to increase the number of bilingual and multilingual staff and support workers. Another important recommendation is to actively promote cultural diversity in research, again, as David mentioned, and as research participants, through public involvement, and as researchers in research funding programs and on research ethics committees. Structural and interpersonal discrimination across the whole health and social care system must be addressed, and necessary funds need to be made available for nationwide as well as local services. And then at regional and local level, policymakers need to develop culturally sensitive health and social care materials for awareness raising and information about health and social care options, promote health literacy, adopt appropriate channels of communication and reach out to people with a migrant background, and develop incentives for health and social care professionals, but be willing to take disciplinary action when necessary. So to conclude, making a commitment to and investing in intercultural care and support are key steps towards ensuring a just society, one in which people with dementia and their carers, regardless of their cultural backgrounds, can live well and flourish. And this commitment must be formally enshrined in relevant policy documents, such as in national dementia strategies. Cost isn't an excuse for inaction. On the contrary, investing in intercultural care and support, including raising awareness of dementia amongst people with a migration background, increasing cultural competence of health and social care professionals, and improving timely diagnosis and developing appropriate services, all contributes towards a healthier population, the creation of jobs, the retention of informal carers in the workforce, and avoiding the cost of managing crises and premature institutionalisation. And then I'd like to thank, by acknowledging the work of the expert working group, and thank you to the Robert Bosch Stiftung for making this work possible. Thank you.
Thank you very much. very valuable information. I think you coughing came over virtually here. The several of the presentations have really been very rich, I feel. And I start seeing already some policy conclusions or beginning of it. So it is very timely, therefore, that John Ryan, Director of Public Health, Country Knowledge, Crisis Management, and DG Santé from the European Commission, is asked to give his response to in this webinar. John, please.
Thank you, Lisa. Thank you, colleagues, for having invited me to this interesting event organized by the European Policy Centre. And I've listened with interest to the presentations of colleagues who spoke before me. I'd just like to give you an overview of the approach of the European Commission, some examples of the process which we follow in developing policy in this area, and also of some projects which we have tried to support. I look forward at the financial instruments which are coming up for the next period. And I'll say something about stakeholder dialogue and also the wider policy framework on demography. So if I kick off by saying that generally speaking in public health, in the European Commission, we work in the framework of the Sustainable Development Goals. The Sustainable Development Goals also have a specific health component, as you know, and they are accompanied, in our case, by the World Health Organization disease-specific targets. So in a nutshell, this is the framework which we use for public health. We don't have our own framework for public health in the EU, but we use the international ones. It's clear as well that in terms of epidemiology, aging and other health factors such as cardiovascular health and so on are leading to a greater burden of disease and including dementia in our population. And I'm not going to go into detail because you mentioned, Liva, in your introduction, the sort of figures we're talking about. These are significant figures for citizens, but also for management of our health systems now and in the future. So therefore, I think it's very good that we put this specific point on the agenda. I'd also mention that migrant populations have specific needs, both at the point of entry into the European Union. And I think we've all seen on our television screens the dramatic pictures of people arriving in large numbers in an unplanned way. So there are specific needs at that point of entry and also later on in their later lifespan as residents of the European Union. The second point I wanted to make is in relation to our legal basis, because our legal basis determines what we can do. There is an article in the Treaty on Public Health which limits our activity or focuses our activity on the coordination of public health actions. So the role of the Commission is to coordinate national public health actions. And we use our health programme as a mechanism to support that coordination. The third point I'd like to make is that working with the Sustainable Development Goals and the World Health Organization targets, we work first and foremost with the member states, since that's what we're supposed to do. We're supposed to coordinate the member states. So we have a specific group which is called the Steering Group on Prevention and Promotion. It's an official Commission institution. And the member states in this group choose their priorities on an annual basis and on a forward-looking basis. So based on what they see as the value added for the European Commission working in that area, and based on what they see as being their national needs, they will tell us that the main areas that they want us to work on, or that they want to work on together, are the following. So it's a member state driven process. They select their priorities, and the Commission on its side then works to take existing practices or interventions which have been evaluated and shown to have impact. So, for example, if the member states were to choose mental health as an issue, and in fact they did so last year, we would then, working with our colleagues around the Commission and in the member states, try and find appropriate best practices that we could propose to the member states, and we would then finance their implementation. So you can see, we're starting with an international framework. We're working with the member states to identify their priorities. We're proposing evaluated best practices, and we're financing those best practices to be rolled out. That's the process which we have in place. To give you a few examples of the type of project which we have financed, we had a member state-led project called Act on Dementia, which contained four main aspects: the aspect of diagnosis and post-diagnostic support. Secondly, crisis and care coordination. Thirdly, the area of residential care. And fourthly, the topic which was mentioned earlier by our colleagues from the King Baudouin Foundation, the support to dementia-friendly communities. So that's a joint action which brings the member states together, and they focus their work on those four topics. We have also supported Alzheimer Europe in coordinating European research and in supporting NGOs working in the topic of Alzheimer's. On the international level, we supported the Global Dementia Observatory with the World Health Organization, which was an initiative taken by heads of government at the time, on which the Commission decided to support. We also had a specific project on migrants' health, developing community-based care models to improve mental health services. And there are a number of training modules as well, which are available online in all languages, have also been supported by the Commission. Looking forward, we're lucky in the European Union that we have a 7-year budget cycle, and we're starting that cycle in January of next year. We already know that there will be a health program and a research program. And both of these programs provide an opportunity for governments and also for research communities and NGOs to do work in areas related to health. And of course, within the framework I mentioned, the Sustainable Development Goals, the World Health Organization targets, it's quite clear that this is an increasing problem in the future. Migrants' health will be an increasing problem in the future. So therefore, it's fully justified that these topics form part of our future funding opportunities. I'll finish by talking about 2 additional points. First of all, stakeholder dialogue seems to us to be very important. It's not an occasional stop and start process for the Commission, it's a permanent process. And we have established a platform. Even before COVID arrived, we had thought of creating a platform for our stakeholder dialogue rather than focusing on physical meetings. The advantage of a virtual setting or platform is that anybody from anywhere in Europe can dial in at any time. They can speak to each other all the time, 7 days a week if they want to. So this platform is the health policy platform. It's open to any stakeholder, government, NGOs, research community, etc. And we have within this platform a number of rooms. If you imagine a hotel with different rooms, you might have a room for mental health. And we have, in fact, a discussion going on in a room on mental health and COVID at the moment, looking at the impact of COVID on the population. But we also have other rooms dealing with alcohol, nutrition, all the typical public health topics. And there, stakeholders can meet together and develop ideas and discuss how to take things forward at the European Union level, working together. The last point I'd like to make is in relation to the policy of the Commission. The Commission has focused its work in the current mandate on developing more resilient health systems. And in particular in the area of cancer, there's a major cancer plan which is being rolled out in the coming weeks. But there is also an initiative being taken on aging and demography. There will be a white paper issued on aging and demography, and we feel it's very important that the topic of health and health issues related to aging should be flagged in this paper. And we hope as well that as part of this process, we can also flag the need to combat inequalities, including in migrant communities. So I hope in a few minutes I've been able to give you a helicopter view of the framework under which we operate, the mechanisms we have in place, the examples of the type of projects we've tried to support, and the financial instruments for the future. Thank you very much. I'd be very happy to answer any questions later.
Thank you very much, John. Very clear, very useful, I think. We'll see. Simona is going to look at the questions in a minute and raise some of the questions. But I would like to ask you, John, very practical, the stakeholder forum. Does everybody have access, or how do people get access to it? And then the white paper on aging and demography. Will there be an open consultation so the people here from the foundations can provide input? I mean, two practical questions, maybe.
So the health policy platform is a virtual platform. It's open to anybody who wishes to join. There are no restrictions. You just have to say who you are and you can register. And we have, as I said, 7,000 registered users of the platform, which is enormous. If you imagine trying to organize a meeting in Brussels with 7,000 people, it just wouldn't work unless you went to the Hazel or somewhere like that. But this platform, the beauty is that it allows for smaller groups to meet together on particular topics. And that's why when the problem of mental health and COVID came up, we immediately opened a discussion on this topic. We agreed with some of the NGO community who should lead the discussion. It's not the Commission. It's a stakeholder-led process. And now they're coming up later this week, actually, with a number of recommendations on mental health resilience in the COVID situation. So just a few weeks after they launched the discussion, they already have some best practices. And of course, we will then on our side see what we can do to actually support the implementation of these best practices across borders. Secondly, you asked me a question about the aging white paper. There will be a public consultation and everybody will have the opportunity to give feedback on that.
Very good. Thank you very much. I think this is useful for everybody here because you have information and policy discussions that you could really raise in that context. Can I hand over to Simona because she has collected quite a few questions already. So if it's possible, it would be nice to be able to direct to whom the question is asked, and maybe we'll take a few before we ask. Okay, go ahead, Simona.
Thank you, Lieve. Thank you for this chance to having a look at the questions which the audience, the participants from the audience put up. There are a few that are interesting. I will start maybe with the question to David. David, you mentioned at the beginning that there is a lack of good quality information at the community level. So yes. The question would be if you have one or maybe two ideas on how to get this knowledge into the communities.
Well, what I'm just about to type, my organisation has a website. It's called, its URL is www.demace.com. And on that, there's several short videos that communities have used themselves to raise awareness in communities. I'm at the moment working on a webinar for educating volunteers in community groups about dementia. The idea is I train them on using this webinar, using the slides that are part of the webinar, to then go on within their communities to talk about dementia, because the slides are in English. The one idea of doing it this way is that we don't have to translate everything into different community languages. What we can do is train community volunteers who already speak a community language and English to go through these slides, translating them as they go, and also deal with questions as they go. So I think video materials in particular are a really useful way of educating communities. But I think the sky's the limit in terms of possibilities. I think an important thing to do is to try to use different types of media, because some people are going to be more at home with getting messages in particular formats than others. So, you know, the traditional thing of putting out leaflets, information leaflets, that has a role to play, but it's a very limited role with a limited section of the population. And just to finish, I think it's really important to work with community groups to do this, because they're often a good source of knowing what will work.
Thank you very much, David. It comes to my mind that in the initial introduction, there was stress about co-producing well-being. Do you see, when you mentioned that the community should be engaged, involved in this process, do you see a role for them in co-producing?
Yeah, I think co-production should be the default rather than the exception. And it should include not just community groups, but people living with dementia and people supporting with people with dementia. It's important to make the involvement with dementia services, dementia research, dementia service development part of something that's normal in migrant communities, in the same way as increasingly some of the health issues have been much more normalized for some migrant communities. Something like diabetes, or say some of the heart, high blood pressure issues, over the last 20 years or so, I would say have become much more a normal part of the conversation for some communities, and we need to go down that same road for dementia.
Many thanks, David. I would now pick another very interesting questions from the audience. This time is addressed to René. We were discussing data about people with a diagnosis of dementia, but the question would be, do you have a way of guessing the real numbers in the communities?
Well, that's an excellent question. There are probably models you could calculate. We are really doing the first steps right now. We know about the underdiagnosis of dementia in general, and this is even worse in people with migration background. So I don't know of any European figures, and what we so I would really be, it would be hard for me to guess a number. We are on the same way right now. What we did with our numbers were, we were relying on the prevalences that were published. So even there is some problems with the numbers. So to make it short, we're in the beginning of really identifying the problem, and with the problem of underdiagnosis in especially people with dementia and migration and with migration background, we are far from knowing the real numbers.
Thank you, Rena. It's a very difficult issue indeed. Maybe to expand a bit the conversation to all the speakers, there is a question from the audience about what can we learn from people with a migration background, and this goes back to the concept of co-creating well-being. Maybe the speakers, do you all want to give your opinion on that? I don't know, wants to start?
I'll start just in terms of, I think there's a wealth of information and intelligence in communities already. And I think that it's important to be able to capture and mobilize that. And I think that's where co-creation creates a unique role for itself.
Thank you very much, David. I very much agree with you. Maybe on the policy side, if John or Diane wants to give us their opinion on this co-creation process.
I could maybe say something about well, we usually use the terms public involvement, but involving people with dementia and supporters and the relevant communities in the work. I think it's important to see this as a kind of a mutual learning process, and not something that once you have worked with a certain community together, that then you have the answer. I think it's an ongoing learning process. I think it's important also, it's a means to break down the barriers. There's a lot of hesitancy. For example, with the funding of the Robert Bosch Stiftung, we've just produced a guide for health and social care workers. And one of the things that we emphasise a lot is that people need to not be afraid to ask. And I think that sometimes it's very difficult to get those contacts in the migrant communities, and also to make the importance of involving gatekeepers when necessary, because it's not that, as people often say, that some people are hard to reach, when actually it's not. It might be more difficult. You might have to make more of an effort to actually get into contact with people from those communities, but it's very important. And sometimes it's necessary to have the help of gatekeepers and to work together. And also with regard to policy, again, it's extremely important. And one of the things that Alzheimer Europe is very much in favour of is the public involvement in the context of healthcare research, which is what David mentioned earlier, in the sense that if people from migrant communities and are not being involved in the research, then the actual policies that are going to be developed, which, as we hear every day nowadays, draw on research, those views are not going to be represented, and the services that are then developed are not going to be appropriate for people from those communities. So it's absolutely essential to involve people with dementia from the communities in actual service development, in the policy making and in the research.
Yeah, I just wanted to emphasize this from a research perspective. I think it's very crucial to include people with a migration background, just to get the bias out of our data, the bias out of our concepts, to increase recruitment. Big problem in healthcare research, and that's not even a question to include them. It's just the problem how to include them. And I mean, dementia is already stressing the nothing about us without us. That's holds the same for people with a migration background. It is difficult, and I don't have a solution yet. But I think it is worthwhile to think about it, because if you design interventions or healthcare interventions not efficient enough, you lose time, you lose money, and it's frustrating for all of us.
Many thanks, René. Maybe, John, you want to give us your opinion on that? And also, I would like to also put to you another question from the audience. If you feel that there is a role for the Commission to take a greater role in this area.
Yes, thank you very much. So involvement of concerned populations is, I think, extremely important and is a key to success. So when we are developing either policy documents or when we are arranging to support through our financial instruments, particular interventions, I think it would be very, very important to make sure that concerned populations have either expressed their views beforehand or are participating in some way in the project. A good example would be what we're doing at the moment with cancer, where the Commission began earlier on this year with a very general consultation involving healthcare professionals, member states, patient groups, all of whom have been very active in bouncing ideas on us for future initiatives in the area of cancer at EU level. When the Commission will be financing some of the identified actions, it will also be extremely important to have the right structures in place so that everybody has everybody has an opportunity to monitor what's going on and to comment on the implementation. We will be setting up a specific group to monitor the implementation of the Cancer Action Plan, and I would hope that patient groups would be extremely active in that context. It's a bit more complicated when you have topics which are ongoing topics like dementia, where you have a series of existing public health and research projects. But I think there's nothing to stop stakeholder communities, whether it's patient groups or representative organizations for the migrant community, to become active and to actually take their role in influencing where public policy is going. So I think it's really important that we try and encourage groups either from the dementia community or more specifically from the migrant community to enable them to participate in this process, because it's an open process. There are the resources that would be needed would be resources, for example, to staff to organize this on the NGO side or on the association side. But we have funds available for that as well. So I think that in principle, there's nothing to stop a greater mobilization taking place of stakeholder communities. It's a question of organizing that on the ground. Secondly, as regards the question on whether the Commission should become more active, I think we have opportunities within the health programme, within the research programme, to encourage research and innovation in the area of dementia and mental health care. But we also have the possibility to actually fund interventions in member state health systems, as I explained to you earlier. So the possibility is there. It's a question of what interest there is from the member state side or from the stakeholder community. And I think from a political point of view, the recognition that Europe has a problem is present in the aging white paper, which I mentioned, the demography white paper. This would be an opportunity to flag this issue quite publicly. And of course, there are also migration strategies which are being discussed at the moment on the basis of a Commission proposal last week. So all of these topics are very much live political topics, and it's just a question of giving the right profile to dementia as an aspect of these bigger policy files. Thank you.
Okay. I can't hear Liv's audio.
Liv, we cannot hear you.
Maybe I can take over. Yeah. Apologies for this, but there is a technical issue. We cannot hear Lieve.
Sorry for that. Somebody muted me. And I cannot unmute. Okay. Anyway, do you hear me now? Yes. Okay.
Yeah.
Sorry.
Yeah.
Sorry for that. I just wanted to say that we are at the end of this webinar, basically. And I would like to ask each of you to maybe say one point or one action that you want to take forward. Very briefly, one sentence, each of you, and I would do it in the same order as you spoke. So the first one is David. Yes.
I think to make more community organisations proactive in their engagement, certainly with the European process, from what I've heard today.
Thank you very much. René.
Well, tough one. I would like to propose a more European approach on the perspective of people with dementia and with migration background in disentangling all the challenges this population faces in the current healthcare system.
That's a big one. Thank you. We have next. I don't see.
Oh, sorry.
Yes. Okay. There you are, Diane.
I'd like to pursue the issue of raising awareness about dementia care and support amongst migration populations throughout the whole of Europe and at the different levels, the different stakeholders, for example, clinicians and health and social care workers and policymakers as well.
Thank you. And John?
Well, my big message would be give migrants a voice. And I think that's probably the biggest problem, particularly if we're talking about migrants with dementia, for all the reasons we heard about earlier on, the cultural problems, the religious problems. We really have to try and figure out a way of giving a forum, a voice to migrants on mental health issues. Thank you very much.
Yeah, thank you. Thank you, John. Thanks to everybody. I want to close the webinar for the moment, but that doesn't mean that the task is done. It's only started. I took a lot of very valuable information, very valuable commitments in a way from this group. So I also still see a lot of work to be done on data, on awareness, on involvement. Yeah, the last thing that John said, the involvement of people with dementia is critical, but it's not easy. So I guess part of the role of organizations like the foundations here are even more important to represent or try to represent the issues about dementia, people living with dementia, and migrant populations. There are double or triple one is there really to do representation and participation and co-creation. But still, it must be possible because it's a real challenge to tackle in the next years. And I think several of you, I hope that you take on board the suggestions that John made also to participate in the consultation processes, because that's a chance to really get into the white paper, into the migration policy in a positive way, with positive actions that can be taken and that can be suggested. I would finally like to thank all of the speakers for very, very interesting inputs, the audience for interesting participation and questions, and the EPC, the Bosch Foundation, the King Baudouin Foundation and EFID for organizing this webinar, and I hope they all work together in continuing that task in the months, the weeks, the months and the years to come, because this is a challenge for all of us in the years to come. Thank you very much and good afternoon.
Thank you.